Welcome to Supporting Breastfeeding in the NICU and Case Studies, the third webinar in our four-part September Breastfeeding Skills Session webinars. I am Amy Gold, the Director of Education for the Partnership for Maternal and Child Health of Northern New Jersey. The partnership is providing today's program. Just a few pieces of information before I introduce our speakers. The speakers and planners have no relevant conflicts of interest. To receive a certificate of completion, you must listen to the entire webinar and complete the evaluation survey. Within 1 hour after the webinar ends, you will receive an email with a link to that survey. Your certificate of completion will be sent within the body of an email next week. This program is being recorded and will be available via the partnership's on-demand education page until September 16th, 2022. Our first speaker for today is Rachel Smith. Rachel has been engaged in maternal child health in the hospital setting for most of her nursing career, the majority of which has been spent at St. Clare's Hospital, although she also did a very long stint at Morristown Medical Center. She has many years of experience as both a maternal child nurse and as a nurse in both Level 2 and Level 3 NICUs. Rachel has been an international board-certified lactation consultant for over 25 years. Today, Rachel will be kicking off our webinar as she looks at supporting breastfeeding in the NICU.
Today, we are going to talk about breastfeeding in the intensive care nursery. This is a very difficult time for families. As professionals, we can make a huge difference in their experience. These are our objectives. Describe how skin-to-skin contact helps mothers, babies, and milk supply. List ways to increase milk supply. Review what mothers can do once they are home. How is pasteurized donor milk used in the intensive care nursery? Describe different pumps and uses for NICU mothers. How to troubleshoot breast pumps. So, there are a lot of things that we can do to help moms, one of which is to get them to the baby as soon as the baby and mom are able. So if she had a C-section, we might be able to put her in a wheelchair that evening to get her to see the baby. Skin-to-skin contact is putting a naked baby on the mother's naked chest. And this helps the baby by helping regulate their respirations, heart rate, temperature, and helps the baby conserve calories. It helps the mother increase bonding. Just having the baby on her chest helps increase the hormones, which help increase her milk supply. It also gives her confidence if the baby kind of works their way down to the breast and starts suckling at her breast. It also relaxes her, and it's so important for the mother to relax because that helps release the breast milk. Studies have shown that skin-to-skin contact also increases the length of time that she exclusively breastfeeds. Not doing skin-to-skin, the babies cry more, and it can lead to a longer neonatal intensive care hospital stay. So what does the mother need when she's in the hospital? So she needs a lot of encouragement. She needs us to help her remember to pump or hand express. She just needs help, creating that bond with her and the baby. So it's important for us to just make her understand that any amount of breast milk she can produce would be helpful to the baby. So the first thing is we would like to get the mom started either pumping or hand expressing within 4 hours of birth, unless she is medically, unless it's medically contraindicated. If she's herself in an intensive care unit, or say she's throwing up a lot. So if there's a reason she is unable to do this, but if everything's good, we would love her to start either hand expressing or pumping in the first 4 hours. And then it's good for her to pump every 2 to 3 hours and 4 hours, and at least 4 hours at night. Providing her with a pumping log can be very helpful, so she knows when the last time she pumped was and how much she was able to get. Let her know that as little as a few drops is normal for the first 48 hours. Sometimes they get a good amount, say 5 or 10 milliliters in the first time or two that she pumps, and then the next few times she gets very little and maybe nothing. This is normal. So what she gets the first pumping or the second pumping is everything that's collected during the pregnancy. And then the third or fourth pumping is just what she got in the last 3 hours. So it's normal for that to vary throughout the day. While she's in the hospital, she should start making arrangements for a double electric pump for at home if she does not already have one. So when we want to get the mom ready to go to see her baby in the intensive care nursery, she may be allowed to do skin to skin when she gets there. So it's important that she has taken care of any of her needs first. Has she eaten or had a drink of water recently? Has she gone to the bathroom before she heads to the intensive care? And has she had pain medicine recently? You don't want her to suddenly be in so much pain that she's going to have to come right back, okay? So that's something that we can help her with. Okay, when she gets home, we also can do a lot of encouraging her to take care of herself. A lot of moms want that special pill or food that's going to increase her milk supply. What I like to work with her is to make sure she's taking care of herself. Those are the basics that helps her make more milk. So is she getting some rest? Is she eating like she's pregnant? Has she been drinking fluids? She should keep that habit of always having something with her. Relaxing is a really hard thing when the baby's in the intensive care unit. So maybe she could be having a picture of the baby or some relaxing music, maybe to hold something that smells like the baby, a hat or something. And frequent stimulation is the most important thing she can do to help increase her milk supply. So she should be pumping about every 2 to 3 hours during the day. She can go as much as 4 hours at night. And her goal is to try to aim for 8 pumpings in 24 hours. Okay. Once she's making a lot of milk, milk removal is how her body knows how much milk this baby needs. And ideally, she should be making about 25 to 30 ounces a day for one baby. So if she has twins or triplets, she's going to be wanting to make as much as she possibly can. In my references, I've included a website where you can see a video on hands-on pumping by Stanford University. This is an excellent video showing moms how to incorporate massage before and during pumping to increase the volume that she can get. The best way for her to transport the breast milk is in a cooler with a reusable cold pack. When mom comes to visit the baby, she should bring any freshly pumped breast milk. If she has some refrigerated breast milk from the last 24 hours, or she should bring the oldest frozen milk along with her. She should talk to the nurse taking care of the baby to find out how much milk they want her to bring in. Sometimes storage is a little limited at the hospital, and some moms make a huge amount of milk and we can't store everything they bring. Pasteurized donor milk. We love having the mother's own milk, and if it is available, we will use that first. But in the level 3 NICUs, they are actually purchasing donor milk for sick and very low birth weight babies. It's such a protective, breast milk, so protective for the baby. It helps give them immunity. It helps seal their intestines. Their gut is very porous at first when they're first born, and so that breast milk helps seal the intestines. It helps prevent a lot of infections. Babies that are very small are at risk for necrotizing enterocolitis, and it's very expensive to keep babies for a long time with what we call NEC. And so breast milk saves a lot of money and keeps the babies much healthier, and they can go home from the hospital much sooner. So that is why the NICUs will purchase donor milk if the mother doesn't have enough of her own. So HUBANA is the organization called Human Milk Banking Association of Northern America. They have an excellent book on every type of question you have about milk storage and pumping and donor milk. And I have their book in my references. So if you know a mother that is making a lot of extra milk and she wants to donate breast milk, the first thing you would do is go to Google milk banking in your area and call a milk bank, and they would screen the mother for lifestyles that over the telephone that would make a person be at risk for certain infections. So like they'd ask questions about IV drug use. So first they get a screening over the telephone, and if you pass the screening on the telephone, then they would have you go for blood work. And after you did pass the blood work, then they would send you all the things you need to pack up the breast milk and send it to them. Okay, so one of the problems in the intensive care nurseries, moms are really anxious and nervous, and often this will lead to a low milk supply. So how can we help her increase that milk supply? So a picture of the baby or something that smells like the baby. She needs to try to relax. She could, when she's home, she could pump in the baby's room. She could be thinking about the baby. Even if this makes her cry, that's the kind of loving, nurturing feelings that she needs to let that milk out to pumping, okay? Often moms are worried or think something's wrong. They haven't heard from the intensive care unit, so they're worried. So even in the middle of the night, she could call the NICU and see how the baby's doing, if that's going to help her relax. Relaxing music in the background or thinking about a relaxing vacation. She can talk to the lactation consultants and nurses about what else she could do to increase her milk supply. I like to talk to the moms about what kind of pump they're using. They may be struggling with a small manual pump at home, and getting a better pump may help increase her milk supply. She should be pumping a few minutes beyond milk flow, that if she's trying to increase her supply. Types of breast pump. So there are manual or hand pumps. These are often used for an occasional pumping, but some moms, if they don't have a pump at home yet, if they can take a manual pump home from the hospital, it's better than no pump. A small electric or battery operated pump is also for an occasional pumping. A lot of the moms have the mid-size personal pump that they've gotten from the insurance company, and often a double electric pump. These pumps are excellent for maintaining a milk supply, but for pumping 24/7, because the baby's in an intensive care nursery, it may not be the best pump that's going to bring in the best milk supply. So I recommend renting a hospital grade double electric pump if she's struggling with milk supply or she's having trouble really stimulating a lot of milk. Okay, so pumping. We want to do that hand expressing and or pumping in the first by 4 hours of age is ideal, if not as soon as possible. It's very important that she is pumping early and often. That keeps those hormone levels up, and that's what your body, what the mother's body needs to stimulate a good milk supply. In our hospital, we will often send to the mother very early after she's delivered a styrofoam cup with a couple spoons from our nourishment center and a couple oral syringes, so she can hand express into that spoon, and the dad or partner can help pull that milk up in the oral syringe. We'll label that with the date and time and the baby's name, and we can send that to the NICU, and they can do mouth care with that right away. The NICU nurses really, really love being able to do that mouth care, and that sends a real powerful message to the mom that even half a milliliter is important for her baby and something that only she can produce. It's very important for them. So we have a pumping log that has the amount of milk that we expect that the mother is going to get each day for the first 2 weeks. And it shows the mom that we're really only expecting a few drops of milk the first 2 whole days. So it takes some pressure. They think they're going to pump and get an ounce as soon as the baby's born. And they're very discouraged by only getting a few drops. But it also gives them an idea that by the 3rd or 4th day, we really should be getting more, and they can talk to the nurses if they're having a problem getting the amount of milk that the log is suggesting that they are making. So now I'm going to demonstrate the breast pump. So this slide is talking about troubleshooting and flange size. Every mom has a different size nipple. Now, in your kit, you'll get a standard 24 millimeter flange. So that is for your average mom. Some moms need a smaller one if they have a much smaller nipple, and other moms need a much bigger one. So in our hospital, we keep the 24 millimeter flange and the 27 millimeter, and that covers 98% of the moms. We also need all the supplies to clean the breast pump and small containers like the colostrum containers, or a smaller GraduFeed to catch the milk in, and labels with the baby's name, and then we'll write the date and time on the label. She should be cleaning her pump parts between pumpings, hot soapy water, air dry, and at home she'll be sterilizing the breast pump kits. Here are our references that I've been talking about. The book called Best Practices of Expressing, Storing, and Handling Human Milk in Hospitals, Homes, and Daycare Setting. Excellent book. Anything you ever wanted to know about breast milk, pumping, storage is in that book. The hands-on pumping, and I've also included the website that you can go to print out the CDC recommendations on cleaning the breast pump. Excellent. We hand this out to all our moms. So now I'm going to go to the demonstration. So today we're going to be demonstrating, this is a Medela Symphony breast pump. So whatever pump you use at your hospital, know how it works and know where the suction is being produced. In this pump, the suction is being produced by this little white flap, which you may not be able to see, but if you have this pump, you'll know what I'm talking about. This pump has suction created by this little white flap here, and sometimes this is cocked, or sometimes this gets a little dry milk under there, and you won't have any suction. So make sure if you can't get suction that you check that little valve. Then if you're not getting suction, just check all your connections, okay? You can open this door and make sure this is connected, okay? Now we should have suction. So with the Medela Symphony, this is the hospital grade pump. It has 2 cycles. It has an initiate cycle and it has a maintain cycle. So those moms just starting out pumping, you want her to do the initiate. You push both buttons, this button, and then this button pretty quickly. If you take too long to push the second button, you're going to end up in the maintain program. If you are in the initiate program, you're going to see circles. Okay, so I'm going to push both buttons, and then she should increase her pressure to about halfway. Okay, let the mom know that pumping should not hurt. If pumping is hurting, then she should go down on the pressure. Okay. So in this program, it has a light flutter suck to start, and then it goes into a much stronger suck. That's why I don't go all the way up right away. So we start in the middle. When it goes to the slower, stronger suck, then you decrease if it hurts or increase if it doesn't hurt. Let the moms know that pain is not going to get her more milk. They think more is better, and that just causes damage to the nipple. If she's having pain, that's damage to the nipple. So just the pressure to comfort and leave it there unless it starts hurting, and then she can nudge it down. Okay. In the initiate program, it has pauses. It will beep when it's all done. Okay, so this will be pumping for 15 minutes, and then it will beep. Okay, the initiate program has a set program, a computer program that produces the most amount of milk for the first couple days. Once she is getting 20 millimeters from both breasts 3 times in a row, she should go to the maintain program. To get maintain, we just push the on button, and then she adjusts her pressure for comfort. It will do the light suck for 2 minutes and then go into a stronger suck. This is the program that they have on their Medela pump at home. So when she heads home, she will be going to the maintain program. I think that's about it. I think we have some questions we'd like to go over.
Rachel, thank you so much for that presentation, and I like the demonstration very much. Can you talk a little bit about other electric breast pumps?
I understand that in the hospital, there are some hospitals that use the Amida pump, as well as other hospitals that use the Medela. And at home, the moms can get a number of different pumps from their insurance company. And some people are using a Spectra, and Amida has a pump for home. Lancino has a pump that they can use at home. Okay, and what I'm understanding is that every mom is different. So a pump that might work for one mom might not work as good for another. So if somebody's having difficulty, they might try a different pump.
Great, thank you. Can a mother increase her milk supply if she's making very little milk and the baby is already 1 month old?
She may not be able to make a full milk supply. The older the baby is, maybe she got badly engorged in the first couple of days and wasn't able to get that milk out. And so bad engorgement can lead to a low milk supply. So it's so important that we're doing that milk removal in that first few days when her milk first comes in. But any amount of milk that the mother is able to produce, even if it's a small amount of milk, is so, so important for the baby. So whatever amount of milk she's able to make, she should keep doing as much as she can. There are ways, like the video I talked about, the hands-on pumping, she could try something like that, or power pumping like every 2 hours around the clock for a couple days. She could do what she could to increase it. Maybe talk to a lactation consultant about what else she could be doing to increase her supply. But you know, there are definitely some moms that aren't ever going to make a full milk supply if they have a low supply at a month.
Are there other conditions that can contribute to a low milk supply?
Absolutely. There are polycystic ovary syndrome, we also call it PCOS. That can lead to an over milk supply, but sometimes it can create a under milk supply. But there's, with that condition, they could possibly take some medication like metformin to help. So she should talk to her obstetrician, especially if she already knows that she has a condition like that. But there are many other things like hypothyroid condition. If the mom's been hypothyroid, she should get her blood work checked because maybe her thyroid is an issue. Any trauma to the mother, like postpartum hemorrhage, if she has just anemia in general, high blood pressure, anything that her body feels as traumatic. Breast milk's optional in a condition that the mother is kind of sick, and so that can be difficult. Let's see. anything that makes the mother's body think that they're pregnant. Okay, so a retained placenta could lead to the fact that her milk never increased until she passes that fragment of the placenta. But also birth control pills, something that creates a situation where your body thinks it's pregnant can lead to a low milk supply.
Can you speak a little more about the use of colostrum in oral care?
Yes. Other than that, it's so powerful for the mother to know that those few drops are so important for their baby. It helps stimulate the baby's immune system by doing the oral care. We can actually swab the colostrum in the cheeks of the baby's mouth. So we'll use a small amount of colostrum for that. And then it has to be fresh colostrum. It can't be refrigerated or frozen. It has to be fresh. So they'll use a small amount of that colostrum, and then will freeze or refrigerate the rest of that milk. And the next time that the mom sends the colostrum, they'll do it again. So they'll swab it in the baby's cheeks, even very, very small premature babies or babies that are not eating, they can give the baby the oral care. If the baby's a little older and a little more vigorous, I'll have the baby suck it off my gloved finger. The baby really likes that, and they're starting to associate the breast milk with eating. So it's so powerful for the baby, and it's good for their immune system, and it's good for their intestines to start that just having that little bit of milk going down into their stomach.
And then the last question has to do with COVID-19. How is COVID-19 impacting mothers being in the NICU to breastfeed their babies or being able to supply milk after they go home? And can you give us any suggestions as to how we can best support those moms?
It is impacting our intensive care nurseries. Depending on how high the COVID rate is in your area, will affect the rules and regulations in the intensive care nursery. When the COVID is at its peak in your area, there are a lot of restrictions about whether the moms can go visit the babies. Even if the baby doesn't have COVID and the mom doesn't have COVID, they are making rules about mothers being in the intensive care nursery at the same time as other mothers. So it is affecting an amount of time that the moms and babies can be together bonding. So some NICUs are making appointments for the families. Sometimes they're only let one parent in at a time. And maybe that time limit may be restricted to only an hour that they can visit a day. And, dad gets to visit one day and mom gets to visit another day. If the mother herself has COVID, then she won't be visiting the baby at all in the intensive care nursery. So it's creating that separation. So if the mother has COVID and she's pumping her milk, we're encouraging her to pump the milk, but we probably won't be taking that milk in the intensive care nursery and feeding it to the baby. She can be storing that at home to be feeding to the baby when the baby gets home. Okay. So we just have to talk to the nurses in the intensive care unit about what the rules are at your hospital and what kind of restrictions. But we really need to be encouraging the moms to pump their milk, get that good milk supply, and get the mom and baby together as soon as we can and as much as we can. But if we're not allowed to get the mom and baby together, we need to be encouraging her to make lots of breast milk and store that for future use, because that bonding with the mother and baby is so, so important. But we also have to think about the huge anxiety levels for even our healthy moms at this time as really affecting milk supply, because all our moms are anxious that, you know, they're going to be exposed to COVID and they're bringing a new baby into this world. And so anything all our moms can do to stay relaxed, snuggle with their babies, just get that milk supply any way they can, and just stay as mellow as they can in their little cocoon at home, can really help them have that bonding and be successful at breastfeeding.
Excellent. Thank you so much for that very detailed explanation and for answering all the questions.
You're welcome. It's my pleasure to be here today.
Our next two speakers are Carmen Baker-Clark and Renia Tsigaras. Carmen is currently the lactation manager at Christ Hospital and Hoboken University Medical Center. Beginning as a La Leche leader in 1998 and then as an international board certified lactation consultant since 2005, Carmen has cared for thousands of breastfeeding dyads in both the home and hospital settings. As part of her current responsibilities, she runs a new mom support group in the Hoboken area, which has made a successful transition to a virtual platform during the pandemic. Carmen maintains a private practice, Breastfeeding Mama, in Bergen County. Renia Tsigaras has worked as a staff nurse and coordinator in labor and delivery and postpartum units at several of our regional hospitals. In her most recent position, she served as the parent education coordinator at Holy Name Medical Center, where in addition to overseeing prenatal classes, she provided both inpatient and outpatient lactation education and support. An international board certified lactation consultant, Renia continues to provide breastfeeding support in Bergen County through the Art of Breastfeeding, her private lactation practice. We are looking forward to learning from Carmen and Renia as they discuss case studies.
Thank you for joining us today for the second part of this webinar, which is exploring case studies of different sorts to help you understand how to intervene and guide mothers along in their breastfeeding journeys. My name is Renia Tsigaras.
And my name is Carmen Baker-Clark.
Let's get started. Case study number 1 involves Miss Amy, who is a 34-year-old, Gravida 1, Para 1, delivered a 7-ounce baby boy via C-section at 39 weeks gestation. The baby is 5 hours old and has not fed. The baby is swaddled perfectly in his open crib, and the father of the baby is in a comfortable position at the mother's bedside. Do you need to intervene? What's your first approach? Carmen?
So the answer to the first question is yes, we do need to intervene. Now, my first approach would be to ask mother how she's feeling. I would come into the room, I would introduce myself to mom and dad, and I would ask mom how she's feeling. Depending on how she answers this question, I will make some suggestions. But the reason why it's so important to intervene is because the baby is 5 hours old and has not fed. And depending on the size, if it's small for gestational age, large for gestational age, generally this baby is right in the middle, so it should be okay. But we still want to initiate, at the very least, skin-to-skin contact and get baby to do first latch. This mom needs an evaluation. This baby needs to experience being on its mother's chest. And usually we'd like to try to do this within the first 2 hours immediately after the baby is born. So if mom says to me that she's feeling pretty good, a little sore, I'll ask her, well, would you like to see your baby? Would you like to have your baby in skin-to-skin contact? And depending on mother's response, then I will proceed to unwrap the baby. We'll talk about waking up baby's reflexes and showing mom how to appropriately place this baby in skin-to-skin contact so that maybe we can stimulate the baby desire to seek the breast and latch on. Once I observe how the baby is doing and we potentially achieve a successful latch, I'll give mom further instructions on how to continue to do this. I will also involve that in participating in doing this, because when us, the lactation consultants, are not in the room, usually we want the father to be involved in helping mom get baby to feed. Those first 12 hours, 24 hours, mom is not too mobile. She's had a C-section, she's going to be on medication, she's going to be uncomfortable and not able to get out of bed herself and go get the baby and put the baby to the breast. So I have to explain to the father that he is going to be the lactation consultant while we're not there and help this baby come on to, first of all, skin-to-skin contact. I'll show them how to correctly do it and then help the baby latch. Sometimes I get fathers to even help shake the breast and simulate baby sucking reflexes. So that would be my first approach. Do you have something to add on to that, Renia?
The only thing that I would add, which you actually touched upon, Carmen, is additional education to both parents in regards to, what we're looking for as far as breastfeeding is concerned, what successful breastfeeding means for that first feeding and for the subsequent feedings afterwards. But I think you nailed all the components otherwise.
I mean, we could
I would intervene.
talk a little bit more about that, meaning like other things that I do as a lactation consultant in that first latch. I do evaluate colostrum. I show mom how to hand express a little bit so we can get a couple of drops. First, it gives her confidence that she does actually have something to feed the baby. And again, it just helps entice this baby onto breast if we can actually smell and taste some of this colostrum. Thanks for reminding me of that, Renia.
Agreed. Agreed. Okay, let's go on to case study number 2.
So case study number 2, Miss Jane, a 35-year-old G2P2, 36 weeks gestation, delivered a baby boy, 5 pounds, 4 ounces vaginally with vacuum extraction yesterday. Mom states she did not breastfeed her first baby because she didn't make enough milk. However, she wants to try with this baby. Baby's urine stool output is within normal limits, and he has lost a small amount of weight on day 1. Mom states baby is latching but unlatches often and insists baby is not getting enough because all he wants to do is sleep. Baby's bilirubin is increasing to moderate risk. Do you need to intervene? If so, what would you do first?
So yes, Carmen, to answer the question, I would certainly intervene. The approach that I would take to the intervention would really involve a lot of education and support. So as far as education is concerned, I would start off by discussing expected behaviors of newborns with emphasis on 36-week gestational age babies and how their very sleepy behavior is common and expected. I would give them additional information on hand expression so that the mother could establish good foundational milk supply, not just from an education standpoint, but also through demonstration of how to actually do hand expression herself, and discuss what we expect as far as milk supply is concerned, the transition from colostrum to mature milk and expected volumes. It is very common that within the first 2 days after delivery, women will not produce very much milk, and anything more than a tablespoon really. And so giving her this information to help reassure her that the expectation is not that they're going to get that level of that volume of milk is important to keep her confidence up. And then last but not least, I would certainly educate mom about what jaundice is, what high levels of bilirubin are in the blood volume, so that she is aware, and how breastfeeding contributes to that, so that she's aware that she can play a very active part in decreasing the chances of jaundice happening. The other component is that I would, potentially observe a latch and guide and support the mother through positioning, what we expect with suckles, what a good latch is, so that we could, again, make sure that baby is transferring milk appropriately, and again, establishing a really good milk supply for her. Most importantly, for her to develop that bond with the baby, so that, because that contributes to the establishment of a good milk supply as well. Anything to add, Carmen?
I wanted to focus a little bit on the piece about the baby is latching but unlatches often, and that that sometimes could just simply be that the baby's having difficulty sustaining that latch for long enough to draw and get the feedback of getting colostrum to be flowing, so that the baby that is getting sufficient colostrum, enough to bring that bilirubin down, to stool often, and then bring the belly down. And I think that I would really, like, as you said, observing that latch, observing that feed, and showing mom ways that she can support mom or support the baby to stay and sustain that latch a little bit better. And of course, if we've seen this scenario a million times, we have run into scenarios where babies are not sustaining, they're able to latch, but they're not sustaining the latch. So we might have to, yes, like you said, hand express into a spoon, and then spoon feed the baby to see if the baby, to be sure that the baby's bilirubin doesn't elevate too quickly, and until we can figure out what is going on with the baby. Any other thoughts regarding that, Renia?
No, I think that's pretty inclusive.
Yeah.
Shall we move on to the next case study?
Sure.
Okay. Case study number 3 is about Miss Mary, a 40-year-old Gravida 1, Para 1, 36 weeks gestation, who delivered a baby girl via vaginal delivery at 30 weeks. The baby is 3 pounds, and she was immediately transferred to the NICU. After a thorough review of the mom's chart, you find that there's a history of IVF and BMI that's greater than 30. The patient is resting comfortably, but is upset. She tells you all she wants to do is to hold her baby. What can you do to help this mom reach her breastfeeding goal?
Well, again, as usual, I want to focus on how this mom is feeling and how to make her feel better, or just reassure her that there's a lot that she can do to help herself and help the baby. It seems to me that it's very important for her to be able to be with her baby. So I would, first of all, facilitate that. If she is allowed. Again, we know we're in COVID times and there's certain restrictions in visiting the neonatal intensive care unit, but I would prioritize that, because that in itself, being able to see her baby, will help this mom begin to have the motivation and begin to bring in some of her milk. If she's able to, or we're able to negotiate, and the baby is well enough to come out of its bassinet or isolate, and we can do some skin-to-skin contact, we can also work on that, again, with permission from the neonatologist and the NICU nurses. Then the second thing that I would do besides reuniting her and taking her to see her baby, would be to set her up with a hospital-grade breast pump and give her the whole education piece on both maximizing her milk supply with pumping and hand expression, and collecting and bringing that first colostrum to the NICU so that the nurses can feed as they see fit, depending on whether the baby is receiving feedings yet or not. The oral care can be done, all of that. Now, there's a little piece that might be a little bit concerning, which is her history of IVF and the BMI. So we can find those two things to be somewhat of risk factors in achieving a full milk supply. But nonetheless, the most important piece is to get her started and to encourage her and to focus on the skin to skin and the frequency of removal of the colostrum. So that would be the first thing that I would do, with her.
Yeah, I couldn't agree more, Carmen. I find that with my experiences with mothers who have children in the NICU, the support that we provide to them is really a crucial piece. All too frequently, we are, myself included, focusing on what we can't do and giving the mother the support so that she knows what she can do to help the situation can be incredibly beneficial for both her and the baby.
It's a fine line that we have to walk, and I think I want to be able to emphasize a little bit the fact that we have a lot of knowledge. We know a lot about how we can help parents, but we need to focus on what it is, the priorities, what it is that this parent wants, and to let them know that we care about how they're feeling. Because then if we establish good rapport and a good relationship with this family and this mother and this father, then we can collaborate and we can work together in a way that's harmonious for everybody, for the benefit of the mom and the baby and the whole family.
Agreed. Shall we move to case study 4?
Yes. So case study number 4, Miss Sharon is 28-year-old G2P1, delivered a baby boy 5 pounds 10 ounces via C-section at 36 weeks gestation. Baby is 3 days old and is being discharged today. Due to mom having breast reduction surgery 5 years ago, mom has been giving formula after breastfeeding her baby at the doctor's request. After thoroughly reviewing your discharge instructions with mom, she excitedly mentions she just joined a mother's Facebook page. She tells you she is so excited that she can purchase breast milk online and not have to get formula anymore. Still, with an excited tone of voice, she asks you, "It's okay to purchase breast milk from Facebook, friends, right?"
So first and foremost, I would answer her question and say that ultimately, it's not ideal that you purchase breast milk from a Facebook friend. And here's why. Really focus on the intent of the person supplying her with the breast milk for purchase, and really educate the mom about how that could potentially raise some red flags in regards to her adulterating the milk, combining it with other types of milk, diluting it, and what have you, enough so that the quality of the breast milk was not optimal. I would also educate this mother about other options as far as receiving donor breast milk and the process that she could go through to obtain that milk, and give her references so that she could be walked through that process additionally, so that she would not have to necessarily buy it. The other component that I would focus on is really supporting her own ability to produce breast milk. Granted, she does have a factor that would potentially contribute to a lower milk supply, and that is the fact that she's had this breast reduction surgery. But I would educate her on ways that she could, produce milk and bond with her baby and be successful with her own breastfeeding journey.
Right.
Carmen, anything to add?
I mean, not every breast reduction surgery is a sentence for a low milk supply. Particularly depending on how long ago it was, the breast can restructure itself, especially throughout the pregnancy, because during the pregnancy we regrow some breast tissue. We may regrow some connections that might have been severed during the breast reduction, particularly dependent upon whether this physician that performed the reduction surgery was mindful and was trying to preserve the connections of the breast tissue so that there would be some viability to her breast and her ability to make milk for the future. So I think I would also add that education piece to mom and just make her feel a little bit better about the fact that just because she had a breast reduction doesn't mean that she can't make enough milk for her baby. So as you said, I would focus on her ability to produce whatever milk she can produce, and she might find that she might make plenty of milk for this baby, or she might find that she make enough that she only has to complement with a little supplementary alternative milk, or whether it's maybe milk from a human milk bank or a certified donor.
Agreed. Okay. Let's hop over to case study number 5, which is about Miss Caitlin, a 39-year-old Gravida 2 Para 2 who delivered a baby boy who's 7 pounds 7 ounces through a normal spontaneous delivery at 39 weeks gestation. There were no complications noted. Mom and baby had a non-eventful first night. The baby is feeding more frequently before his discharge, and mom mentions that she's tired, and she tells you that she must not have enough of a milk supply. What can you suggest?
So this is, there's a lot that can be suggested. And I think we all always start with education and explaining baby's behavior, particularly that when we get into that second day and second night, that famous second night with babies are really revving up the frequency of feeding, because our purpose to that behavior is to really bring in mom's milk. And it can be very overwhelming. So I like to tell parents about it. I try to kind of like anticipate it a little bit so they're ready for it, they know what to expect, because then if they know what to expect, then it doesn't seem as overwhelming. And they don't blame themselves. They realize that this is a normal newborn baby behavior for a 39-weeker born right in the middle of our weight charts. That if she goes with it shortly, hopefully within the next 24 hours or a little bit more, her milk will come in. Her baby will have done the job of bringing in her milk. So things to suggest to help her get through it is to divide labor with her partner. Make sure that the father, if mom becomes a little bit overwhelmed, then the dad takes turns to hold baby. And bring baby to mom whenever baby needs to be feeding. Also hand expressing and maybe having a little bit of colostrum supplement with will kind of maybe give her a little bit of a break or maybe a longer stretch between feedings. It would also want, of course, hopefully I will be able to observe a feeding and give mom all my pointers and tricks to help make sure that the baby's actually transferring milk effectively. And that's a very important piece of the education that we do as lactation consultants, is to really thoroughly observe a feeding. Not just check the latch from the outside, but watch the baby suckle, explain to parents that this first 48 hours, babies do a lot of suckling and just a little bit of swallowing. And if they can teach them how to distinguish between what a suckle is and what a swallow is, and tell them that as their milk comes in, they're going to see a lot more swallows in relation, or in as a more of a 1-to-1 or a 2-to-1 or a 3-to-1 suck swallow ratio. It's just empowering, again, sharing of the right information for this particular situation, given that mom's main complaint is that she is extremely tired because the baby's been feeding so frequently. And her conclusion, as we often hear, is that she must not have enough milk. But to reiterate, we just let them know that this is a normal behavior that has a very important purpose, that her baby is doing the job that it's supposed to be doing.
I couldn't agree more, Carmen. I would like to just add and reinforce the confidence piece in all of this, in that many mothers will tell us, both in the hospital setting and in the private setting, that I don't have enough milk. And providing them with the education that they need to understand what is an appropriate amount of milk for their child and how to determine whether the child has gotten enough milk, giving them techniques to boost and maintain their milk supply, and also focusing on building her confidence, because I personally find that that is the piece that many women struggle most with, is aside from not having the education and the information that we have to share with them, feel that they can't do it, they don't know how to do it, and really, like you said, empowering them to be as involved and committed, and let them know that they can do this.
And Renia, this is what we do all the time.
Yes.
We are constantly, I think this is probably the #1 piece situation that we hear about in the hospital setting. I don't have enough milk. I don't know that my baby's getting enough. My baby's feeding very frequently, and the conclusion is I must not have enough. And I repeat myself continuously, letting them know that their baby's actually doing a very good job in doing exactly what they're supposed to do, and that he is telling her body how much, he or she is telling her body how much milk to make. And the more that we respond to this frequency of feeding, the more milk she will be able to make down the road. It's interesting. I want to also mention that there are many studies that were recently done regarding how the frequency of feeding the first 24 or 48 hours immediately after the birth of the baby actually has an impact on the mother's milk volume production at 3 weeks, at 6 weeks, 3 months, and even further down the road. If the baby does get to come to the breast and feed quite often, those first 24 and 48 hours, it has a direct impact on total volume down the road. So, and we do our best. Some people are very receptive to that kind of information. Some people might not be as receptive, but we try to accommodate each individual family's needs.
Agreed. Repetition is a vital portion of the support you provide to breastfeeding dyads. Agreed. Carmen, it's been a pleasure doing these case studies with you and providing some information to our viewers. Thanks so much for taking the time to do this with me today.
Thank you, Renia. It is an absolute pleasure. I love collaborating with you. It's great. Thank you.
Thank you, Renia and Carmen. It was great hearing this lively exchange of ideas. I'd like to thank all of our speakers, and I'd like to also extend my thanks to Monica Smith, who handled the technical back end of this program. Just a reminder that within the hour, you will receive an email with a link to a post-program evaluation. Certificates of completion will be sent to those who complete the evaluation, and you should receive them via email next week. The partnership's Breastfeeding Skills Session webinar series concludes next Thursday, September 24th, with 2 of our regional lactation consultants presenting use of breastfeeding tools and paced bottle feeding. In addition to our webinars, the partnership has a variety of resources to support new mothers who are breastfeeding. Our Sisters Who Breastfeed program in Paterson and Jersey City is a collaboration with the Perinatal Health Equity Foundation. This support village is for Black women who are breastfeeding or plan to breastfeed and offers virtual support, connections, and resources. More information about Sisters Who Breastfeed, other resources for families, and upcoming professional educations can be found at the partnership's website, partnershipmch.org. We encourage you to check it out. Thanks for being with us this afternoon.